Good day. So I'd like to welcome you all again to another installment of our ongoing series called The Power of Pivoting, Managing Through Crisis, a series of discussions with key HSS personnel describing how we have responded to the COVID-19 crisis. I am Ronald MacKenzie, MD, an internist and rheumatologist at Special Surgery and professor of clinical medicine and medical ethics at Weill Cornell Medicine, and I serve as the moderator for this series. Now, one of the interesting developments, certainly to rheumatologists, of the COVID-19 crisis has been the emergence, certainly in the public eye, of some of the medications that we use to treat our conditions. These are medications that are probably somewhat obscure to many of you, and this seemed like an interesting topic to bring to the public for discussion. And today, we have asked one of my colleagues, Sebastian Sattui Cortes, our vasculitis fellow, to talk to us a little bit about rheumatic disease medications and their potential relevance and role in the treatment of COVID-19 infections. This is a matter of some ongoing controversy. So welcome, Sebastian.
Thank you for the invitation.
So, I thought maybe what might be a good way to begin, because some of these medications aren't that widely known to the lay public, to talk a little bit about the medications we use to treat rheumatic diseases, and maybe with a little focus on the ones specifically that have emerged in the public eye, such as the anti-malarials and a few others, actually.
That's great. So certainly what most people have heard of so far has received a lot of attention in the media and by different leaders worldwide, has been the use of Plaquenil or hydroxychloroquine. Hydroxychloroquine is an antimalarial, but that has been around for years. And in the rheumatology world, it has a very established position in the management of multiple of our conditions. It is used basically because it has shown some anti-inflammatory properties, and there are multiple studies that back up its use. It's used extensively in lupus, systemic lupus erythematosus, both the systemic form and the cutaneous forms as well, rheumatoid arthritis, Sjogren's, some undifferentiated connective tissue disease, and continuous manifestations of other conditions. With regards to the data that backs up the use of hydroxychloroquine in patients with rheumatic diseases, I think specifically in lupus, that it's widely used, and in most of our patients, unless it's not tolerated, there is very solid data that backs this up, including landmark trials such as the Canadian hydroxychloroquine study group that showed that when patients where hydroxychloroquine was stopped in patients, they were at an increased risk for flare, an increased risk for disease activity, and 5 times more likely to even have severe manifestations of their disease. So Plaquenil or hydroxychloroquine has a very important role in the management of our patients. On the other side, there's been quite an excitement and an interest for its use in the treatment of COVID-19 or coronavirus, the current pandemic that we're dealing with. This interest is not specific to COVID. It has been already studied in the past in multiple other viral infections such as influenza, such as chikungunya or Zika, where in vitro studies showed some improvement and some hints of viral clearance. However, the data didn't translate into clinical studies. This increasing interest was actually sparked by a study that came in from Marseille, France, that showed in a very small group and a study with multiple criticisms, where even the current journal is actually not backing up and saying that this study didn't actually reach the standards required by the journal. It showed an increase in the viral clearance in the patients treated with hydroxychloroquine compared to controls. However, as I said, the controls used in the study were inappropriately selected. There were significant differences in the study as well. This was a small study using a surrogate endpoint, which we don't know how it translates into clinical outcomes as well. But certainly this was enough based on the attention that it received by social media, by press, in order to massify the population's interest in the use of Plaquenil, and led to an excessive prescription and potential drug shortages that have affected patients who depend on this medication.
So, the putative usages of the antimalarials have been, of course, to treat the acute infection. I know, though, that in the public that people have used it in minor forms of the infection or even as prevention. So you're telling us that really basically on what information is available, that there really isn't sufficiently strong scientific evidence from clinical trials to justify that?
So after this initial study, several studies have come out, and even some of them showing increased viral clearance, some of them showing some improvement in symptoms, while on the other hand, some studies have shown no improvement in viral clearance at all, no improvement in symptoms, or even the biggest concern from most of us who are used to using this medication, side effects. So the jury is still out there, and the problem right now is that most of these studies, even the ones that have positive or negative results, have serious methodological flaws. There still are small studies with underpowered for their conclusions, with surrogate outcomes that are not necessarily looking into what we want, is improvement in patients who are dealing with this infection. So I think the jury is still out there, and it's important for us as physicians not only to interpret the information adequately, but also to transmit this information to non-physicians or non-scientists, because people are concerned, people are anxious, and we need to be sure that they are aware of what is really being shown or what is not being shown right now. And with that point, there is also the concern on studies now showing the risk of side effects, and especially this combination with hydroxychloroquine and azithromycin has shown an increase, and as we all know, has an increased risk for cardiac complications, including dysrhythmias and significant cardiac mortality as well. There's some studies that show that even in non-COVID population, that patients with hydroxychloroquine and azithromycin are at increased risk of mortality. And this was a large study that was recently released. It's still kind of in preprint, but this was using patients with RA and compared patients who were on hydroxychloroquine and azithromycin to another antibiotic, I think it was amoxicillin, and it showed that there was a significant increased risk of cardiac mortality. So we need to be only not concerned for what this medication, if this medication is helping or not. We also need to be concerned of what potential harms are being done. There are 2 studies that have been done using chloroquine, which is a different medication than hydroxychloroquine, certainly, but it's the same proposed mechanism. And they've both been stopped early because of issues with side effects and no improvement in clinical outcomes. So it's important to be looking, one, to strive for adequately designed studies that look into this. Unfortunately, they are going on, but for that information to get collected, analyzed, and released, it will take time. But to advocate for adequately designed studies, and at the same time for dissemination of those results in a responsible way.
There are a number of other, let's say, higher order medications we use in rheumatology that are being employed also in the extremely sick COVID patient with essentially pneumonia and adult respiratory distress syndrome. Things like tocilizumab and anakinra, which I understand you've had a little bit of experience with, and maybe we could just conclude.
Yeah, so there is certainly a group of patients with COVID, and there's kind of all the case series coming worldwide that are showing that patients who present complications from COVID, not only pneumonia, but as you said, ARDS, are a specific subset of patients, some of them, who have this state of hyperinflammation, what we commonly deal with in our world, and certainly other specialties as well. This term is called a cytokine storm syndrome, which basically is your body responding to a stimuli in an excessive way, to the point that it stops not only dealing with infection, but at the same time causing harm to the body. And that is where the role for immunomodulatory medications such as tocilizumab, which is an blocking IL-6 agent receptor, And there's other studies going on as well with sarilumab. There's another anti-IL-6 agent. So tuximab, that doesn't belong that much to our world, but it's also an anti-IL-6 agent, and anakinra are playing a role. I think there needs to be caution with the use of these medications as well. The same as Plaquenil, not only because we can potentially make the infection worse, but this, which is a reality. We're dealing with an infection, so there needs to be a good study, a multidisciplinary approach to these patients, kind of including infectious diseases, pulmonary critical care, rheumatology for sure. That's an important role that we need to play. Hematology as well, because a lot of these patients are having a quite interesting prothrombotic state that needs to see specifically which of these patients actually benefit from this medication, because there is certainly a fine line, and that's what we're seeing in some patients where they deal with the infection, but when this kind of hyperinflammatory state takes over. But at the same time, we need to use our medications in a wise way, because there is also a line where calming down the immune system might help. But then if we start completely blunting the body's response to the, not only to the virus, but to the risk of, to other bacteria that or other infections that get superimposed, that needs to be careful. This is, I think, a lot of these patients are on ARDS, but there needs to be a good set of criteria and trying to actually pick the patients who would benefit from this, which is difficult in the current situation, which is difficult kind of with the mortality that we're experiencing. But at the same time, our role is to do good and no harm. So it is imperative that physicians and specialties kind of work together in this.
So Sebastian, just from a therapeutic standpoint, and I know we're only about a month in, is there anything you know now that you wished you had known 1 month ago?
To be honest, I think not much of and this is my personal practice has changed right now. I think we've come to learn more of how this virus is presenting. So I'm even more suspicious of anything right now that is
Viral,
completely like usually initially I was asking about like cough, the fever, and what we already have all been asking for, but there are more and more cases of, especially in geriatric population, of confusion and no fever, so nothing else until several days when they're already admitted. So I think right now my suspicion for it is very high. I have a very low threshold to be asking more and more questions and keeping a close monitoring of my patients. With regards to medication, I think I stand where I was at the beginning of this, given that not much of the information has come out to guide us, but I think we've had a lot of our impressions and a lot of our decisions or our thoughts have been reinforced by the American College of Rheumatology, by the ACR, and I think it's good to have that, and their position and their actions on this current situation have been just exemplary. Social isolation and kind of recommendations for patients have been the same from the beginning, and I think with some other registries of patients with autoimmune conditions, hopefully, and there's always an issue with reporting, staying low. I think it speaks to the communication that we have with our patients and the precautions that we've advised of them since day one of this, and that needs to stay. And we're gonna have a tough time with the recommendations of what comes after this as well, because certainly this is going to be something that will be a stepwise approach. I hope to see more information coming on soon to better guide us and our patients, but as of right now, that's kind of my change.
So another problem faced by rheumatologists, Sebastian, is that many of the medications we use to treat these conditions are inherently immunosuppressive. So may the diseases themselves be. So what recommendations are being made then regarding a patient, for instance, with lupus on a variety of medications as to what they should and shouldn't take?
So I think, fortunately, the American College of Rheumatology, who has been very active during this current pandemia and has been not only an advocate for their patients, but also guiding us with this, have released recommendations regarding how to manage the situation with our patients. both addressing our concerns and addressing our patients' anxiety with regards to the risk for infection. As of right now, we're certainly dealing in uncharted territory. We really don't know. We all, as rheumatologists, knowing what you just said, that their medications are immunosuppressive, have the concern that our patients are at higher risk. And until proven otherwise, we need to take that approach. That being said, stopping medications also puts our patients at risk, of increased disease activity, used for other medications like steroids that we certainly fear probably as much or more than most of our other agents. Patients who flare might need to be seek medical care, be in an ER that would expose them to exposures, would put them at risk of exposure. So there needs to be balance. This needs to take into account what is the condition, what is the state of the condition prior to making any decision about changes into medication, and this needs to be a personalized decision. I think that's the most important take-home point. The patient needs to be involved in the decision, and kind of things need to be weighed into what are the risks, what are the benefits. On top of any changes to medications, what patients need to be certainly advised for is for social isolation, hand hygiene, staying away from any sick contacts, and just trying to do this to the best of their possibilities to actually protect themselves, as anyone else should be doing, but especially patients with rheumatologic conditions. With regards to medication, the American College of Rheumatology is saying in patients who are not having any symptoms concerning for COVID, that they will err on the side, especially taking into account in patients who have severe manifestations of our disease, saying lupus patients with nephritis, vasculitis patients who've had a kind of significant organ damage, for them to stay on their medications and to kind of be closely monitored. In the case of patients who have suspected infection or active infection, certainly there is a recommendation to try to minimize doses of steroids, stop medications, to try to not alter the body's immune response to the virus. There is a growing interest regarding use of some of our medications, of course, and especially the biologic agents for the treatment of COVID complications. But as of right now, we don't have any evidence that necessarily says that patients are going to be at less of a risk for being on them or not. So we need to kind of be cautious about this and try to discuss things as much as we can, but also just act.
So let me just give you an example. It occurred this morning on that subject, which was a nurse that I've looked after called me. She has quite stable rheumatoid arthritis. She is on Plaquenil and she is on methotrexate in a modest dosage, not a high dosage. She works in an outpatient clinic and is concerned because she is about to be deployed to an in-hospital setting to care for patients with active COVID-19. Her question really had more to do with what should she do with respect to her medications. But there's a secondary question, which is, should a physician counsel her not to do that?
That is certainly a tricky question, not only from the side of the medications, but as healthcare workers, as physicians, we want to rise up to the occasion and help as much as we can. And that's, I think, an important role that we're all trying to take part of. With regards to specifically to the medication, Plaquenil, I think it's not going to put her at any risk. There's certainly enough of a background or rationale for her to stay on it, and that I think that's fine. Taking that she is again on the medication chronically for the management of her underlying condition, not because there's any data at the moment that is going to prevent her from getting the infection. As of right now, all the information or the studies that have been done or published or in preprint for Plaquenil have been on patients with documented infection who are having symptoms, either mild symptoms or severe symptoms. There is no data at the moment for either prevention or prophylaxis or even post-exposure prophylaxis. There are currently 3 trials going on right now in the US. I know there's certainly others worldwide that are looking into post-exposure prophylaxis, but we don't have any results of them yet. So I think same with Plaquenil is reasonable. Staying with methotrexate, it's a little more of a decision that needs to be between you and the patient. I think depends on where her disease has been before this, how much protection is she's going to have in the care of patients as well. And I don't think there's a straightforward answer, unfortunately. What we do know as well is that if she goes down on her methotrexate and she flares, she's going to be symptomatic. She's not going to be able to function correctly if she has a high burden or high disease activity. She's not going to be able to work correctly as well. And at the same time, having a more active immune system in our patients doesn't necessarily mean that it's an immune system that is working correctly as well. So I'm going to say that this is something that certainly needs to be discussed with the patient, because I don't think there's a right or wrong answer right now. With regards to what to work or not, I probably have less of an answer for that either. And it's up of the comfort that someone will have, the amount of protection and PPE that we have access for, which certainly is a main concern for all healthcare workers.
Thank you. So I'd like to bring this session to a conclusion and have Sebastian tell us a little bit about his international efforts in this domain with his Global Rheumatology Alliance.
So the COVID-19 Global Rheumatology Alliance is a group of academic and community rheumatologists and patient advocates as well that was formed on March 12th of this year in the midst of this pandemic going on. And I believe it has personally been just a wonderful experience, and it's shown and reaffirmed to me the wonderful community that we belong to. The rheumatology community has taken action quite fast in order for us to be guided and obtain information to guide us and guide our patients through this current situation and this current emergency. It basically started as some conversation on Twitter from different physicians who said we should do this, and people started jumping in. That's how I got in. It's currently led by Philip Robinson, who's an academic rheumatologist in Australia, and Dr. Jinus Jasdani, who is the chair of the department of UCSF. But now there's at least over 300 or 400 providers in the email list. We have the support of at least 100 organizations worldwide, including the American College of Rheumatology and the European League Against Rheumatism, and other professional societies, patient societies as well, and different institutions. The goal of the registry right now the main goal is to what we have going on right now, which is the registry, is for physicians. We have a provider registry and a patient registry. So the provider registry is focused on physicians reporting their cases of patients with rheumatic conditions with a COVID infection, for us to understand what are the risks for our patients, what is their condition, what medications they're on, how bad was their disease, what presentations did they have, what symptoms did they have, in order for us to communicate that. And this information is getting sent into social media and emails to providers worldwide in order to have a little bit more of information, which is unfortunately what we don't have right now to deal with this pandemic. There is also a patient experience survey that is targeted for patients who have or don't have the infection, in order to understand how are patients dealing with this current situation. What are patients doing that probably is helping them to not have the infection, or at the same time, what are our patients who are suffering the infection are doing. But besides the registry, which is constantly releasing information, and there was a communication in the Lancet Rheumatology yesterday with the first 110 patients. Right now, the physician registry has, I want to say, over 500 reported cases, and the patient survey experience has, I think, getting close to 9,000 entries. There are other scopes of the GRA as well. A lot of us are involved in systematic review literatures in order to guide us better with what is the role of our medications in the treatment of COVID, what are the risks of our medications in the treatment of COVID as well. So we are actively doing that. And there's a lot of advocacy and communication as well for both rheumatologists and our patients. We are releasing some information as well, including the fact that we have documented cases who were on Plaquenil. showing that, again, these are, I think there were like 37% of the cases that were reported some weeks ago, but showing that Plaquenil is not preventing absolutely anything. Again, this is a small number and needs to be managed cautiously, but at the same time, the claim of Plaquenil protecting everyone from this, or that lupus patients are spared, I think is incorrect, and the GRA is trying to reinforce that. Hopefully this will continue, and it's very important for both physicians and patients to continue providing this information, because this information is directly going back to all of us. It's not being kept, it's being actually communicated frequently in order to guide us in this current situation.
Well, Sebastian, listen, thanks so much for doing this, and particularly for your work with the Global Rheumatology Alliance. I think it's really quite stunning that something could get up and running of that magnitude within, what, a month?
Yeah, actually, the registry and the survey and everything was set up in a couple weeks.
Yeah.
And then, yeah, it's been a lot of fights of that. But yes, it just speaks to the community, the proactive community that we belong to, which is, in the midst of all this, I think it's been encouraging for sure.
Well, thank you very much.